started. Welcome to the 116th session of the Weekly Huddle. I'm your host, Anoop, and joining me today is my friend and co-host, Praneeth. We both are cardiologists working at KIMS Hospital. In the Weekly Huddle, we talk about clinical topics, we talk about decision-making, and once in a while, we restrict our discussion very focused on particular drugs, on particular entities that we want to delve in a little bit more. And today's discussion is on one such topic. Now, this is our 116th session, and if I can recollect myself, there have been few episodes where we have discussed about the pharmacological property of certain drugs. Earlier, we discussed about bempedoic acid, which at that point was a very upcoming molecule for lipid management. Currently, it is almost available on every drugstore. One time when we discussed about nitrates, which is our good old friend, and that was during the discussion where we learned that the IV nitrate has 30% alcohol into it. So you can actually cause people to develop alcohol toxicity by giving too much of IV nitrates. We discussed about novel oral anticoagulants in at least, I would say, 2 sessions. And it's been quite some time that we had discussed about oral anticoagulants. So the reason why we bring up these particular topics referring to pharmacology is because either some of these medicines are so common that we have stopped learning about it, or sometimes these medicines are the upcoming pharmacotherapy, upcoming medications in the field of cardiology or fields which are related to cardiology, where we are expected to know about these drugs. Whether we use it or not, it really doesn't matter. The idea here is that these drugs, they will be in the market, and our patients or our colleagues will be asking us about these drugs. So it's not only why we should prescribe it, but if we end up not prescribing it, we better need to have a reason why we wouldn't prescribe a drug which already has got a guideline recommendation. So with this theme, we are talking about heart failure management today. So the case which I'm discussing is a 55-year-old male. He was recently hospitalized for heart failure admission. That heart failure there wasn't any obvious trigger for that heart failure recurrence. There could be some non-compliance with salt and water restriction, but overall, there was no any active trigger that could be identified. This patient had a recent short trip where he stayed at his relative's place over a weekend. Whether he consumed a high salt load there, that is difficult for me to ascertain. Historically, does not seem like quite obviously. He was in the hospital for 3 days, 1 day in the ICU and then 2 days in the room. And subsequently, he was discharged in his baseline status. He also has got history of diabetes and hypertension, both of which are long-standing, that is more than 10 years, and they seem to be reasonably controlled. The background is he has got ischemic cardiomyopathy. He has 2 stents placed. Both were placed around 10 years ago. The first one was in the LAD as a part of acute coronary syndrome, and the second was in the RCA as a staged intervention. Both were done around 19 years ago, for which we don't have good data set. His ejection fraction has been maintained somewhere between 35 to 45% over the past 10 years, and he had been in class 2 to class 3 baseline symptoms, mostly class 2 symptoms, except these occasions of exacerbation which lead to heart failure admission. So this particular heart failure admission was about 2 weeks ago. As I said, he stayed 3 days in the hospital. Now this is his first follow-up. He seems to be doing all right. He doesn't have any active complaints. His vitals, which is relevant in today's discussion, includes heart rate of around 72 to 73. He's in sinus rhythm. His blood pressure is around 110 over 70. He's saturating fine. And overall examination suggests a euvolemic status. His routine lab evaluation done at this time is okay. The discussion for today is less particularly on the clinical management of this patient, but more in relation to the role of Vericiguat in patients like him who have heart failure. So this particular patient, when he was discharged on goal-directed medical therapy, which included beta blocker, ARNI, mineralocorticoid receptor antagonist, as well as SGLT2 inhibitors. So he had been on all 4 of these medicines. Out of these 4, mineralocorticoid receptor antagonist was a new medication on discharge. All other medicine he was taking even prior to admission. So now he comes, he has got other random medication that he takes, and you are thinking whether this patient is a candidate to start Vericiguat. So as we all know, it's a newer molecule. It was US FDA approved last year. The reason why we haven't been talking more about this drug lately is because up until now, because it was not available in India. And very recently it has been launched. So if you are practicing cardiologist or if you are internist who is practicing non-invasive cardiology, you will be seeing a lot of attempts to solicit your attention on this particular medication. So it's very prudent for us to learn about what this drug does and where and how to use, so that we don't get consumed by other external forces which are more commercial in nature. So the question that I want to highlight particularly with this drug, is this patient a candidate for Vericiguat treatment at this time? What are the dosing strategies and what are the drug interactions that we need to worry about Vericiguat? How do we use it in special population, like particularly this one, or if there is any other special population that one can think of? Vericiguat and Riociguat, we have been using Riociguat for quite some time. So are these medicines same? Do they work on the similar spectrum? What are the differences between the two? Are we trying to relabel a pulmonary arterial hypertension drug to a heart failure drug? And lastly, is Vericiguat poised to be the 5th pillar of heart failure management? We know currently that there are 4 established pillars of heart failure treatment, which includes beta blocker, ARNI, MRA, and SGLT2 inhibitors. So can Vericiguat be placed on the 5th pillar for heart failure management? Just to give you an idea about the guideline aspect. So the US FDA currently does not include Vericiguat in their heart failure management because their last guideline was released before US FDA cleared Vericiguat for its use. European Society does mention Vericiguat as a third-line treatment for heart failure, but they have not given it a very high regard in terms of recommendation because of the newer drug and less data available. So that is the overall background that I can set in for this particular medication. Praneeth, I'll start with you. What is your thought about it? These are the kind of patients who come to you quite regularly, and I'm pretty sure that you have been solicited to prescribe these medicines. Do you think there is a role? Do you think these medicines have a suitable role in heart failure management in Indian context? And if yes, if you could highlight some of the questions that I brought up, like dosing strategies, drug interactions, and all those things. Praneeth, all yours.
Yeah, good evening, everyone. So, heart failure disease is quite prevalent, and we deal with so many patients with heart failure with reduced ejection fraction. So, any new drug which think will help this subset of patients is always a welcome. In that regard, this new molecule has come up, which, as per the current data or the literature, seems to be promising. And if it is so, then it is always a welcome where patients can get better. Now, regarding Vericiguat, it essentially kind of increases the nitric oxide, I think based on the cycling GMP mechanism. So essentially it is promoting vasodilatation, and with the vasodilatation probably is helping in preventing the negative remodeling which happens in patients with heart failure. So, and that is where it is kind of helping the patients with heart failure. The current drugs that we have, or we know right now, the quadruple therapy that you are mentioning, ACE inhibitors or the RAS blocker, particularly angiotensin receptor neprilysin inhibition, SGLT2 inhibitors, mineralocorticoid receptor antagonists, and beta blockers. We know that these patients have low ejection fractions at the moment you start any of these drugs, particularly the ARNIs or beta blockers, we end up having hypertension. And equally, these drugs can kind of restrict heart failure decompensation. I believe this drug also, because promotes vasodilatation, the one thing that I would like to, what I would be worried is the incidence of hypertension, and probably that will be the first common side effect that I would be looking into, or that is one parameter which I will be watching for if I have to prescribe this patient. Then, how effective is this drug? The two important parameters that we look into for any of these drug in terms of any patient with heart failure is one, the longevity, the survival or improvement in mortality, and second thing is the heart failure hospitalization. So most of the trials have looked into these two parameters as primary composite endpoint, and even for this, it is the same two primary composite endpoints which we look into it and whether it improves. If I remember correctly, this drug kind of the primary composite endpoint met the statistical significance, and if we look uh, deep down, the majority of the benefit that was offered was probably with the improvement in reducing the heart failure hospitalization than in improving the longevity. So that is one thing which we look into it. But any advantage is an advantage, even if the patient improves in heart failure hospitalization, it is still a welcome. Regarding the dosing, I believe the standard dose that they have tested was 10 milligrams a day. And the information that I got is that this drug is available in three strengths, 2.5, 5, and 10. Probably understanding the Indian population being susceptible to hypertension, be it with ARNI, also we know that though ARNI, the standard dose is 200 milligrams twice, majority of the patients can tolerate only 50 or less than that, 50 milligrams per day. So similarly, for this molecule, we may have to start with one-fourth the standard dose, that is 2.5 milligrams once daily. And if the patient can tolerate it, then you up titrate from 2.5 to 5, and then maybe 10, which is this, which was the dose which was tested in the trial, which got approval. Other side effects that has been reported is as anemia. I exactly don't know the mechanism of anemia in these patients. Probably some interaction with iron metabolism. This is something that seems to be unique to this molecule. We also know that iron deficiency is prevalent in heart failure patients, and IV iron has been recommended to improve outcomes in patients with heart failure with reduced ejection fraction. So, does this molecule impair the already impaired iron homeostasis in heart failure patient? Is something that we should be looking for. And regarding this patient, the index patient, can this patient receive Vericiguat? For this patient, because he was up until now fairly well tolerated, or this was the only recent event, probably the change in his this thing could have precipitated. So I do not believe that this drug will probably make a difference to him. I would still wait. I would still rely on the quadruple therapy, which have been more consistent in improving the outcome. So I would first try to look into optimizing them, try to go maximally tolerated doses. If I am not able to give any of those four drugs, or if the patient is not tolerating, then probably I would try test this Vericiguat. In this patient, I believe it is too early for me to consider Vericiguat. For this patient, I would currently wait, and I would reassure the patient and optimize on the quadruple therapy, and then take it forward from there. These are my thoughts on this molecule and this given patient alone.
Thank you, Praneeth. Because we have thin attendance today, what I will do is I will continue my discussion with Praneeth. But if any one of you have got any thoughts or questions or suggestions, please unmute yourself. You can directly unmute yourself and share your thoughts. I wouldn't be picking on any one of you for your thoughts, because I can understand that these are newer drugs with less information available. And so, Praneeth, I heard what you said. Preventing any heart failure admission, what we have learned, is always a good idea, because it reduces the cost, it reduces the overall burden, and the hope is that over the long term, it also will reduce the mortality. So here's my thought to you, and then you tell me how do you process it. Just give me a second. So first of all, I will tell you about the dosing aspect of it. So the trial with which the drug got approved, that trial actually claimed that 10 milligram is the actual dose. The 2.5 and the 5 milligram were just a run-up dosing. So they were given in the first 1 month just to let the body get used to it. But the trialists also list that 10 milligram is the therapeutic dose. Unlikely our beta blockers and other drugs where even low dose has got therapeutic benefit, in this particular drug, at least what is advertised is that 10 milligram is the therapeutic dose. So, Praneeth, in the Indian market where this drug is launched, to my understanding, the tablet costs about 100 rupees per tablet. I'm just going to give you a rundown of my assessment. This is how I assess whenever I look at these kind of drugs. You tell me your impression, and then we can ask opinion of our attendees also. So the indexed trial that you mentioned, in about 11 months, in about 1 year, the absolute reduction in event rate was about 4%, and that 4% is mostly heart failure rehospitalization, not mortality. So one can argue that 11 months is too short to look for a mortality benefit, but remember, you have got data from SGLT2s as well, where the mortality benefit starts becoming quite obvious. So in 11 months, your absolute risk reduction of 4% for heart failure hospitalization, which gives you a number needed to treat of 25. So the way I see it is you have to treat 25 people over 11 months to prevent one heart failure hospitalization. And if I take the drug cost as 100 rupees per tablet, I'm talking about 8 lakh rupees. So I have to spend 8 lakh rupees to prevent one heart failure hospitalization. Now we know even in private or corporate setup, if we ignore the mortality aspect of it for a second, then one heart failure hospitalization will have a ticket price of maybe 2 lakhs, 2.5 lakhs, something of that sort. So here a drug is introduced which says that you will spend 8 lakh rupees to prevent one hospitalization. How do you justify using these kind of drugs for heart failure hospitalization reduction? Or in your opinion, every admission which is prevented is worth no matter what is the cost you got?
Right. So for a heart failure patient, your analysis of preventing a heart failure hospitalization and the amount incurred to the patient is absolutely valid, and that is how equally I look into it. So that is where the cost benefit analysis comes into, and these drugs, even though they seem to be showing some benefit earlier, but the cost which is associated with these drugs kind of makes it prohibitive. Same is the case with the ARNI drugs, which are still expensive because it is still patent. Same is the case with evolocumab, the drugs for lipid lowering. Hence, though they are very good drugs, that the prohibitive cost makes them less cost effective. If the patient is already in an advanced heart failure, and if he is having recurrent heart failure hospitalizations, because we also know from data that rate of rehospitalization within 1 year is close to 30%. And if a patient has 2 to 3 hospital admissions within 1 year, we may be justified, but in no way it should be the reason to consider that this drug should be used as a thing to prevent heart failure hospitalization. I would look at is key focus on the current drugs which are there, like RAS blockade and beta blockade, MRA, and currently SGLT2s. Thankfully, SGLT2s right now are not that expensive. Beta blockers and diuretics are still manageable. ARNI is still expensive. Hopefully, in few months, it's going to come down. If not ARNI, at least give age-old angiotensin, ACE inhibitors, whereby we can kind of reasonably manage these patients. If these drugs are not able to be prescribed due to whatever reason it is, be it hemodynamic instability or some other reason, then if patient is okay to afford, then probably you consider. If not, then probably I would not be inclined to prescribe these molecules, because currently the cost effectiveness doesn't justify for me to prescribe this molecule.
Okay, then, and as I said, I'll continue my discussion with you, and I again remind my attendees, if you have any thoughts or questions, either you raise your hand, unmute yourself, or put it in the chat box. Even if you have a question, something that is unknown about this drug, then we will take this question up. Praneeth, what is your experience with Vericiguat? What is your thought about? Are they both the same drugs? Are we just remarketing these drugs, or do you have less clue about it? What is your thought?
So Vericiguat is, again, I believe, belongs to the same group of molecules. They also increase endogenous nitric oxide release. Vericiguat, in my knowledge, has been used in pulmonary hypertension space, and both belong to the same group. But as per the literature, I believe this drug, Vericiguat, has been tested and seen to be effective in heart failure subset. Vericiguat is been tested in pulmonary hypertension subsets with efficacy. How do they differ molecularly? I don't know, but I believe they kind of have very close morphology and very close relationship. Maybe some difference, and whether that really has a difference in their mechanism of action in two different vascular beds, I doubt, or I do not have that enough information. But Vericiguat experience with me is limited. Many of the patients who have pulmonary hypertension, my experience with pulmonary hypertension is limited. And equally, again, most of the drugs which are used for pulmonary hypertension, when you go beyond your PDEF inhibitors like sildenafil and tadalafil, majority of them are again expensive, which kind of is prohibitive for most of the patients, and they do not afford, or they just test it for maybe a month or so, and they stop using them because of the cost, which they cannot afford. So my experience is limited enough, and I believe they both have very close morphology, both Vericiguat and Vericiguat. I would like to know more. My knowledge is limited here.
But whatever you said, one thing, you seem to make it very clear that you probably wouldn't have a patient taking both Vericiguat as well as Vericiguat, right? There probably wouldn't be a patient taking both the drugs, right?
Yes. It may lead to a devastatingly hypertension. So you are not supposed to mix both of them. So either this or that.
Does that also mean that when we have got patients who have got, let's say, higher pulmonary artery pressures, maybe in the severe range, maybe in moderate to severe range, whose PA pressures are driven mostly because of left-sided failure, that is the most common etiology of pulmonary hypertension. Do you think in those kind of patient subset, we may actually make a case of using Vericiguat preferentially over other drugs? Now, since we know that it's a brother of another drug which is used for pulmonary hypertension?
Technically speaking, or theoretically, it sounds right. that this is a drug which has been approved for this subset of patient, that is heart failure with reduced ejection fraction. And if these patients are equally having pulmonary hypertension, then technically they should also be benefited by some reduction in pulmonary hypertension because of the some resemblance to Vericiguat. So theoretically, yes, but whether that theory has been, or this hypothesis has been tested, we need to know if we look into the subset analysis of the population, whether how many of these patients actually had pulmonary hypertension, and those subset of patients how did they fare in comparison to those who did not have significant pulmonary hypertension. I think that is definitely should be looked into or should be analyzed.
Pranit, we'll continue our discussion, and I see Santosh in the audience. Santosh, you are probably one of the youngest doctors in the attendees right now. I'm sure you are keeping up to date with the newer data. If there is anything you need to add, or if you think we are missing on this particular drug, or if you have a question, please feel free to unmute yourself or participate in the discussion. Yes, Santosh, anything?
Yeah. I know, sir. I still believe the four drug classes which are very essential. Once we optimize those four drugs, essential drugs of heart failure, the patient is still symptomatic. One can consider Vericiguat. Again, sir, I have not prescribed this drug, and my knowledge regarding how to go about, including doses, side effect, and all in this thing is I don't know much about this drug, sir.
Thank you, Santosh. I think that optimization with the existing quadruple therapy, while it is significantly advertised, I will ask this question open-ended, that how many of our patients are on therapeutic doses or target doses of beta blockers or ARNI or whatnot. Now, we also have to understand that the index trial, because of which this drug got approved, that index trial was enrolling patients at a time when both ARNI as well as SGLT2 inhibitors were not considered standard of care for heart failure therapy. So in that particular trial, GDMT essentially meant ACE inhibitors or ARB, beta blockers, and MRA. So SGLT2 was not there, ARNI was not there. So the data that you are getting is more real world than what, while it's a randomized data, it's a more real world data in the current context where a lot of our patients are not on proper GDMT. That actually brings up this question that what will happen if you actually put patients on good quadruple therapy? Will Vericiguat have any additional benefit? And truly speaking, I don't think anybody knows the answer to that question. That once you start if you start with these four drugs, will Vericiguat have any additional benefit? Remember, less than 10% of patients in the Victoria trial had all these four drugs. In fact, SGLT2 inhibitor was probably not even existing at that point of time. So optimizing GDMT is the optimal way to go. But once you optimize GDMT, then the question remains even more unanswered, that in those particular subset, whether Vericiguat have got any role or not. I'll continue my discussion. Praneeth, another question that is going to come up is, because this is a drug which kind of deals with or shares a lot of its properties with pulmonary hypertension space, how do you see it with sildenafil? Let's say a patient who is on sildenafil, where the mechanism of action or the field of work of sildenafil and this drug is similar. Would you combine these two drugs together if the patient is on sildenafil for some reason?
I believe, again, as we were discussing about the combination of Vericiguat and Vericiguat having a potential chance of significant hypotension, the similar contraindication with any nitrate and sildenafil, I believe these two drugs also should not be combined with the potential risk of significant hypotension. All these patients are already have lower blood pressure, and any of those drugs which promote further vasodilatation, we may end up having significant hypotension, and that itself can lead to a decompensation and a heart failure hospitalization. So, whenever we give these other drugs, the potential interactions should be taken into consideration. So, I believe all these drugs. If I may add, probably the other drug that we use with for heart failure, that is isosorbate dinitrate and hydrazine combination. Even with that drug, I believe can equally lead to hypotension and decompensation. So both PDF inhibitors like sildenafil, tadalafil, and these nitrate combinations should be avoided when we are considering Vericiguat.
So you did mention about nitrates, Praneeth. That was my other follow-up question. That because these drugs, they work on nitric oxide pathway, and we may have a lot of patients who are on nitrates, particularly in some sort of combination like the one that you mentioned in the form of isolazine. These patients who already are getting nitrates, and now you give a drug which works on nitrate pathway, there is definitely a chance of them developing significant venous pooling, leading to reduction in preload, causing hypotension. So that is definitely another aspect to look into. If you recollect the Vericiguat story, which is used in pulmonary hypertension, it has got an almost exclusive indication in chronic thromboembolic phenomena, chronic thromboembolic pulmonary hypertension, where Vericiguat seems to be one of the frontliners in managing pulmonary hypertension because of pulmonary thromboembolism. Now, in those patients subset also, if those patients are getting sildenafil, and if we switch to Vericiguat, it's a very standard practice to stop sildenafil and switch to Vericiguat to prevent those hypertensive episodes. As most of you know, that Vericiguat is a 3 times daily dosing, where you start with a very low dose and slowly up titrate. And often Vericiguat is combined with drugs like macitentan, Opsort, which causes less hypotension than drugs like sildenafil, which works on phosphodiesterase inhibitor pathway, phosphodiesterase pathway, leading to potentially more hypotension. So we did mention few drugs, sildenafil, nitrates, and on the same line, if the patient is getting any other anti-hypertensive drug like your calcium channel blockers or whatnot, then those drugs also probably need a little bit of caution when we start these drugs. Although when you look at the index data, then the average systolic blood pressure which was reduced with Vericiguat was 2 millimeters, and that was statistically non-significant. So at least data-wise, whatever we have, Vericiguat does not seem to be precipitating hypotension if used in good selected patients. But drug interactions definitely can make it worse, and that is something we have to be careful in case if we decide to use this drug on the patients. One question that comes is in the chat box is, any drug we use in heart failure always should show mortality benefit? Isn't it enough if drug improves quality of life or heart failure admission? Santosh, I think you joined a little late when we were discussing about this drug, this heart failure hospitalization. So I did a back of the envelope calculation using the number needed to treat and the drug cost. And the number that I came up was 8 lakh rupees. So essentially what it means is you have to spend 8 lakh rupees in India to prevent 1 heart failure hospitalization using Vericiguat in those patients who are not GDMT optimized. Once you have patients who are GDMT optimized, in those patients, maybe the absolute number will be even lesser. So the total cost of preventing 1 heart failure hospitalization may go up even more. So the question here is that from the economic aspect of it, what is worse, spending about 4 times to 5 times the cost in preventing 1 heart failure hospitalization, or we believe that any heart failure hospitalization is bad because it increases the overall mortality of patients. So even if you prevent 1 heart failure readmission, that's always a good idea. Remember, the good old drug digoxin was shown to improve heart failure hospitalization, but has never been proven to improve mortality. So, not that we can always correlate 1:1. I hear where you are coming from, that heart failure hospitalization can translate into mortality if we follow these cases long enough. This particular trial was for 11 months. If we follow it for maybe 3 years, 4 years, maybe we will get mortality signal. It is just that so far we don't have any. And in the lack of hard clinical data, economics or finances have to be considered when we are putting these drugs into perspective. So that is my answer to your question. I'm sure it is not a straight yes or no answer, but we have to consider all of that when we are prescribing these drugs. So anything else, if anybody has to mention? Praneeth mentioned about anemia. Anemia is is one of the signals which is used in this drug. The idea here is that this drug, it does bind to the iron molecules and probably interferes with the iron pathway, leading to drop in hemoglobin. The absolute number in the trial, I believe, was 0.3 or 0.2 grams per deciliter. So the absolute drop is not much. But again, these are, randomized data set. In your clinical practice, your mileage may vary. But you do have to be mindful, particularly those patients who have slightly lower hemoglobin to begin with. And as Praneeth was mentioning, that in heart failure subset, there is very good data that IV iron supplementation actually improves the overall outcome of these patients. So maybe it's a good idea that when we are considering starting patients on Vericiguat, then we make sure that their iron reserves are repleted, and that they are not bordering towards anemia, and where we would expect that about 0.5 gram of hemoglobin might go down by using this particular drug. So that is another thing that we have to pay attention to. Vericiguat does have a black box warning for pregnancy. So our patient subset, typically, this is not relevant. But in case if we are dealing with young women, particularly postpartum or non-ischemic cardiomyopathy, then we should absolutely make sure that they are not pregnant. If they are in childbearing age, maybe we should do a pregnancy test before we start Vericiguat in those patients. I'll just give one more basic factoid about this medicine, that when FDA approved this drug, then the approval was for patients who had got an ejection fraction of 40% or less. Just so that you know what kind of patient subset you are going to put this medication. So the ejection fraction was 40% or less, and these patients, they either needed to have a heart failure admission within 6 months, or they required IV diuretic therapy in the past 6 months. So the idea here is that these are the patients who had a recent deterioration in their heart failure, and those are the patients for whom this drug was approved. In the subgroup analysis of the data set, what they also found is this drug was not quite helpful in extremes of presentations. What extremes of presentation means, those patients who had got a milder degree of heart failure, like ejection fraction higher than 40 but less than 50%, those patients who are on class 1 to 2 failure symptoms, in those patients, the response rate was not good. And also the other end of the extreme, those patients who are very sick, whose anti-proBNP were very high, who are in very bad heart failure, even in those patients, this drug didn't do that well. So you can probably choose. This particular patient would be a good candidate for Vericiguat because this patient had a recent hospitalization. There is no reversible cause that you need to fix. He's already on all the 4 GDMT drugs. So patients like the one that I presented would be a good candidate for Vericiguat. And there is no renal or hepatic dose adjustment. So that is one less thing to worry about. When you do end up prescribing these medicine, you really don't have to worry about what their renal clearance or what their hepatic clearance is. So that is all that I believe there was to learn about this particular molecule. You are going to see it more frequently around you. If it stands the test of time, it is possible that it may become one of the third line drug for our armamentarium. Praneeth, anything to add about Vericiguat?
I think you summarized it well. The only issue is probably we need more studies and more data to know maybe which subset of patients among those heart failure patients that this can be used. Maybe those patients whom you are not able to give any RAS blockade, probably then we can use them because of hypertension, or any of these patients who have associated maybe valvulopathy or some associated coronary artery disease, non-reversible. Probably in those subset, I'm just thinking while I'm talking. So maybe any selected patients it might show because of its advantage of nitric oxide release that these patients maybe get a slightly better advantage into that. But as I said, any new molecule which has been studied is always a welcome. And I hope if it can kind of show improvement in any of those patients, it is always good. And maybe this equally can lead to development of a new molecule which has a better effects. I believe this can be a starting point. So just like neprilysin inhibition, which by isolation did not show any benefit, but with combining both the neprilysin inhibition and ARB, RNA kind of shows a benefit. So I am looking forward that this could be an initiating for something bright in the future. So those are my thoughts on it.
So cost is definitely something that we need to be considerate about. At 100 rupees a pop, it's almost like if you take ARNI away, then a patient typically would pay 100 rupees for rest of the medication combined. So if we are adding one drug, which is as costly as the rest of the medicines that the person is buying, then at least we should try to justify why we are adding all this cost to the patient. The good thing is it's a once a day drug, doesn't have a lot of interactions with electrolytes, with blood evaluations and whatnot. So there isn't much observation that you have to do other than few drug interactions that we discussed previously. Second thing is, because it's a newer drug with less data, this is also an opportunity for a few of us who want to do some studies or trials in their respective centers. Maybe it's a good idea to just sub-select few patients who are on reasonable goal-directed medical therapy, put them on this drug, and look at their tolerability, their overall outcome. We will get not only data which is pertaining to the Indian subset, but also data in patients who have been optimized with GDMT. So newer drugs also gives us these kind of opportunities now, since it is accessible to us, where not only we can talk about its clinical benefit, but also add knowledge to the academic medicine that we have. So that is all that I had to discuss about this particular medicine. If nobody has any questions or comments, I will ask Somaraju sir for his opinion about particularly this molecule, but also the overall evolution of how heart failure pharmacotherapy has happened over the past few years. Somaraju sir.
Good evening, Anoop and Praneeth and everybody. And it's very nice that you brought up this new entity, but at the outset, I must accept and say that I have no knowledge and experience with this drug yet. I'm learning in this presentation you have, and I'm yet to try. Having said that, I have a few things to talk about in heart failure in general and the existing drugs. As you already mentioned about beta blockers, RAS inhibitors, aldosterone antagonists, and resynchronization therapy, ASCDs. Each one of these things they showed benefits from almost 10% to 30%. It's almost
I found some web results.
total.
I can show them if you ask again from your iPhone.
If you total all this, it is more than 100% benefit actually. Interestingly, so it's not heart failure anymore. It's heart success with all these drugs. But one starts wondering whether it's better to have heart failure to live longer. With those published results about each of these drugs individually and technologies individually. Having said that, now that there is so much benefit already shown by each of these drugs in isolation and combination, any more new drugs you add, it will be very difficult to show benefit. Benefit is difficult to prove, but absence of proof is not proof of absence in this situation. And secondly, we try to ignore the issue of, say, hospitalization only, but no mortality benefit. But hospitalization itself is mortality. The risk of hospitalization itself is one, and the financial toxicity involved in it. And also, we were never able to show, as one of you pointed out, digitalis and its benefits, and also even diuretics. Imagine none of these drugs plays a role of diuretics in acutely failing patients, heart failure and hospitalization. If that patient didn't survive with the diuretic therapy, what will these drugs do? So in other words, there is a lack of holistic approach in the management of heart failure and interpretation of the results. Reductionism is still a way of approach in medicine, and combining things together. And when you say heart failure, it's not a single subset. Each patient is different and all of them look different. So looking at all that, the answer are not going to be simple. Guidelines are not going to help all the time. Sometimes even mislead you. Individualization is the key. And don't give up on anything new that comes up, because the benefits are sometimes artificially shown to be high, and randomized clinical trials will never give the complete answers. So we don't have enough evidence yet. Thank you.
Sir, I have a question for you. You mentioned about the accumulated benefit of each of those drugs, and if we add up, it's hilariously becomes more than 100%. I think this has been discussed in multiple editorials before. I want to understand your perspective. Now, 30, 40 years ago, cardiology was in a different spectrum altogether. So I don't want to go that far back in time. But 10, 15 years ago, where we still had modern cardiology was still doing a very good job. We had good drugs, we had good interventions. We were in our medical school at that time. You were practicing at your peak as always. Is there an obvious difference now in terms of heart failure management now, since our armamentarium is a little wider than what it was 10, 15 years ago? You think that those numbers which we talk about in trials and guidelines and all this, do you see them translating in your clinical practice, or you think they are all gimmicks and we have reached the peak of how much we can help heart failure with medication alone?
Yeah, actually, it's a very important question. Just like many other diseases, heart failure, the face of it changed, the incidence, it has become more common, and with the aging population and many forms of management methods available, and including, say, interventions that preserve myocardium and prolong life, the chance of heart failure are progressively increasing, and atrial fibrillation and heart failure cannot be separated from each other in many situations. The aging population, the commonest admission in ICU and acute care units today is not myocardial infarction, it is heart failure. Having said that, there is a significant benefit shown by each of these entities. But again, some of these patients, almost Dr. Kanu Chatterjee used to comment and even wrote in his book, the patients in whom the existing beneficial therapies are not helpful or may not help, and there is around 10 to 15% of these patients. We still don't have answers to those things, and some of these newer methods may help or may never help. But finally, one has to accept that heart failure is better prevented than treated. Thank you.
Thank you so much, sir. If nobody has any questions or comments, I'll ask Praneeth to give a short wrap of today's discussion, and then we'll close the session after that.
Yeah, no, I think the pharmacological topics are definitely important to revisit. And I think we sometimes take things for granted, but it is always good to discuss these things. And equally, this issue of newer molecules, because not everybody will be having time to discuss these things. And if we can kind of make it as a summary of what we know and what is the carry home message, is definitely a good thing. So I think this today's session is definitely valid in that regard. So Vericiguat, newer molecule, which is currently available in the Indian market for heart failure with reduced ejection fraction subset, not with other subsets. So any patient whom you should consider the LVEF be 40% or less. The current recommendations are the quadruple therapy, which have class 1 recommendations, angiotensin receptor neprilysin inhibition, beta blocker, mineralocortical receptor antagonist, SGLT2 inhibitors. After that, if you think this patient still has some juice left and we can add something, then please do consider Vericiguat. The standard dose is 10 milligram once daily. You start with 2.5 and gradually up titrate. Once you hit 10 milligram, that is when the drug actually starts working. Two important side effects to mention is one, hypertension, and second, anemia. And no contraindications being other vasodilating drugs, that is nitrates, PDEF inhibitors, etc. And stressing on heart failure optimization on titrating the other drugs to the maximally tolerated dosing. And I think the cost is currently prohibitive, but if those patients who can afford and whom indicated, please do consider this molecule. And these are my take-home messages from today's session.
Thank you, Praneeth, and thank you all of you for attending today's session. As you all know, we do it every Wednesday. So we'll come back next Wednesday at 7 o'clock with a new topic. Till that time, goodbye and good night. We'll see you next week. Take care, guys.